The other thing that we ask about in the medical history nowadays is pornography, because the use of pornography, because it's all online now, has increased, over the past years, and we're seeing increasing numbers, particularly of younger men, whether diabetic or not, who perhaps have unrealistic expectations, or they're not matching up to what they see in the movies, develop erectile dysfunction for psychological reasons. So we always ask nowadays about pornography.
Okay, thank you. And so you're going to tell us a bit now about the treatments that are available. What sort of treatments might you offer as a specialist dealing with this?
Sure. So I'll come to those. I'll come to those now. But just before I come to that, one of the important points I want to raise is this business of having a PSA blood test. So in men, and in black men over the age of 45, one of the reasons that we see men with erectile dysfunction is because actually they've got prostate cancer, or prostate enlargement. So in any man that we see over the age of 45, any black man over the age of 45, whether they've got diabetes or they haven't, we would always do a rectal examination, and we would do a PSA blood test. And we regularly pick up prostate cancer in these men. So because you have diabetes doesn't necessarily mean that that's the cause of the erectile dysfunction. It might be something else as well as.
Frank, that's a tremendously important point, and thank you so much for raising this. You are an internationally renowned expert in this field of prostate cancer in black men. So thank you so much for that, because you raise another issue which I used to encounter sometimes, that people would not be clear in their own mind about whether things like going to the toilet very frequently, having to get up at night to pass urine, having urinary difficulties was actually due to prostate problems or diabetes. And sometimes it was a little bit tricky to establish that, but I think it's something that we have to bear in mind, and also like worsening of those symptoms. So you might be living with diabetes, and then you get this worsening of a urinary frequency, going to the toilet frequently, and you're not sure, is that due to my diabetes or is that due to something else developing? So thank you very much, Frank, for raising that. That is an area that we wanted to highlight because, of course, we're focusing on diabetes, but we don't want to forget other issues that disproportionately affect us as African and African Caribbean people. So thanks for that, Frank.
Thank you. So we've made the point earlier, and I'll reiterate it. Quit smoking. Quit smoking. You can see how it's causing a droop in what should be a straight organ. Treatment options. So we'll move on to treatment options. If there's things that you can modify, such as stopping smoking, getting your weight down, then do so. There's a role for sexual counselling to get your mind right. But we're going to be talking mainly about oral agents, what we term local therapies, and surgical therapies. So these are ways of not curing the problem, but ways of getting an erection when you want to get an erection. Okay. So I've mentioned psychological counselling. So the main line is tablets. So we've had tablets around for perhaps 20 odd years now. Viagra was the first tablet. We've got 4 tablets that help get an erection. Viagra, Cialis, Levitra, and Evenifil. You take a tablet half an hour to 1 hour before anticipated intercourse. Sexual stimulation is required. The tablet just doesn't work unless you activate the brain and the mind. So foreplay or erotic literature. And then within 30 to 60 minutes, if it's going to work, and these tablets don't work for everybody, but if it's going to work, then you will get a decent erection that will perhaps last maybe 15 minutes. I'll point out the tablet Cialis on this slide has a long duration of action. In other words, if you take one tablet of Cialis, it'll still be active in your bloodstream for about 36 hours, which means that if you had sex in the night, you would need to take another tablet the next morning or even the following evening. Compared to the other tablets, which only last for a short time in your bloodstream, so you would have to take another tablet the next day.
And Frank, just to say, as a healthcare provider, what we'd always want to do is to discuss these medications with you, looking at your whole medical history. Because remember, we were saying that, if your blood vessels to the penis aren't working as they you would hope they would do, that can signify that blood vessels in other parts of your body, so like your heart, may also be affected.
Yes, and for most people can take and tolerate these tablets. There are certain contraindications. So there are certain situations in which we would not recommend to take one of these tablets. The main one being if you've got angina, which is where you get pain, chest pain on movement due to your coronary arteries being narrowed, and you're on a drug called nitrates, then there's interaction between that and these tablets. So before we start someone on one of these tablets, for example, Viagra, we always take a drugs history to make sure that the man isn't on one of these drugs that may cause a problem. So one of the things that at times we'll see a man, he's diabetic, he's tried, let's say Viagra, he's tried it 3 or 4 times, it's not worked, and then he gives up. And at times it doesn't work because there's not enough sexual stimulation beforehand, or he's had a very big meal, or he's had too much alcohol, or at times it just takes a while for the body to get accustomed before it starts working. So don't give up too soon is the message. Some of the tablets are more likely to work first time than some of the other tablets. But the point about this slide is that if something doesn't work the very first time the man tries it, he thinks that's it, it's never going to work again. That is not the case. Don't give up too quickly. So we are able to convert some of these tablet failures into tablet successes by talking about sexual stimulation, then have a big heavy meal, and how long in advance of sex you have to take the tablets will vary from man to man. So it might take several attempts before it actually kicks in and starts doing what it's meant to do. So
just to say, Frank, very quickly, that that is so important, because quite often I would have people coming back to me in the consultation who've seen other healthcare professionals who hadn't explained to them about how to take the medication. So they'd just been given the prescription, off they'd gone, they'd tried it hadn't worked. But as you said, they might have had a heavy meal, they might have had an unrealistic expectation that the first tablet was going to be it, that they didn't require any sexual stimulation as well, that it was just going to be take the tablet and it was going to work. So it's so important with everything that education, isn't it? We talked about communication, but education is always really important as well. So you're going to talk briefly about the other treatments that are available, but people can get further information about this from their individual healthcare provider. So back to you, Frank.
Yes, so most men will start off with a tablet, but that will work for maybe 6 out of 10 men. The tablets will work for. If it doesn't work, then what next? Do you give up? No, because there's a lot more that can be done. So one of the other ways of getting an erection is putting this. It's called Muse, M-U-S-E. It's a prostaglandin that's in a small pellet that you insert down the urethra, as you can see on the slide. So again, maybe half an hour, 40 minutes before anticipated intercourse, you insert this little device with the pellet drug at the end of it and insert it down your urethra. rub the penis, sexual stimulation, and then that can also give you an erection. It's more invasive, of course. It's not as easy as just popping a pill, but it does work. There's certain advantages and disadvantages. The main disadvantage of this application into the urethra is about a third of men get pain with it. If that doesn't work, what next? Well, there's a cream called Vitaros. This is a cream that you can insert into your urethra in a similar way to that pellet, but rather than a pellet, this is a cream. And again, you rub the penis after inserting this cream, again 30 to 40 minutes before anticipated sex, and that can often work in terms of giving you an erection. The thing about these things is that the next time you want an erection, then you have to put another application. None of these treatments are curative. They will work for that particular instance. What if that doesn't work, or you just don't want pharmaceuticals? Then you can use what's called a vacuum pump. A vacuum pump is a plastic cylinder that you put over the penis, and you pump the air out of it. That creates a vacuum within the cylinder. Penis becomes erect, and then you slip a rubber ring over you remove the cylinder, slip a rubber ring over the penis down to the base to keep the blood in, a bit like this. So this shows a diagram. Plastic cylinder over the penis, air is pumped out, penis becomes erect due to the vacuum having been formed within this plastic cylinder. And then you can see there's a rubber ring is applied to the base of the penis to keep the blood in. Now, after intercourse, you remove the ring, and the penis then flops down. So this is a very good way indeed of getting an erection without drugs, without pharmaceuticals, and this can be incorporated into foreplay. Now, I've seen men who've tried a vacuum device, and I say, "Where did you get it from?" And they said, "My local sex shop." Now, in the sex shops, they do sell things like this, but they're not medical grade, and they don't work particularly well. So if you're going to try a vacuum device, I would get one that's of medical grade, medical standard, and then it's a good idea if someone shows you what to do with it. So what if the tablets don't work? What if you just don't fancy a vacuum pump? What if the pellets or the cream into your urethra don't work? Then what next? The next thing is what we call intracavernosal injection therapy. This is basically there's drugs that you can inject into the penis, as in the diagram. You can be taught how to do this. These are drugs you inject into the penis, maybe 20 minutes or so before you wish to get an erection, and it works well. It works well. Of course, you have to get over, and in fact, diabetic men find this quite straightforward because they're used to self-injecting, especially those who are on insulin anyway. They're used to self-injecting, so they don't have a problem with the dexterity that's required to inject the penis. It's a very, very fine needle, so it doesn't actually hurt. So we teach men how to do this, and there's various drugs that you can inject, and it gives a very good erection. So this will work maybe 9 out of 10 men diabetics. Compared to the tablets, like it's 6 out of 10, for example. So intracavernosal injections. So that's a good option. Certain advantages is that it works well and it works quickly. The disadvantages are that you need some manual dexterity to use it, and not everyone wants to inject themselves. So what if that doesn't work? So the kind of final option I'm going to talk about is what we call a penile implant. It's possible to insert, this is an operation, these kind of silicone rods into the penis. It's all concealed so you can't see anything. There's a little pump, which again, it's all hidden. The pump is placed between the testicles. And when you squeeze on this pump, it takes fluid from the reservoir, which is the big balloon you can see, into the cylinders, and the penis becomes erect. So there's different types of these devices. I'm just going to talk about the inflatable prosthesis. So when it's not activated, the penis is just flaccid, it's normal. And when it's activated, you can see the penis becomes erect. It works where everything else has failed, but it is a surgical procedure, and there are risks attached to any kind of surgical procedure.
So thanks very much for that, Frank. So, I mean, essentially, we're moving from oral treatments, so things that you can take by mouth at your convenience, to more complicated and more invasive treatments which are available. But the important thing to say is that there are treatments that are available. The other important thing to say, as you said, is that they're not cures as such. So, Frank, thanks very much for that. So there's lots of different options of treatments and managements that people can try. And I think the important thing is that they either see their GP to get the more simple options that they can take themselves at home and try themselves at home, and or to be referred to specialists like yourself for the more invasive or complicated options. Would you agree with that?
Yeah, absolutely. And just to mention, many diabetic men have a deficiency in their testosterone, and if this is the case, there's ways of boosting their testosterone, which will help with their erections. So you can take testosterone by mouth or by injection or by skin pads. And just to round off, to re-emphasize the importance of communication, both with your partner and with your healthcare professional. Erectile dysfunction is very common in men, and it's even more common in men with diabetes. And you're not alone. There'll be many others, even though other men may not share what's going on in their lives. So don't be shy. Seek help, and the earlier you seek help, the better. Thank you very much.
Thanks very much for that, Frank. That is so enlightening, I'm sure, to lots and lots of people. And I one of the things that I remember is how individual this is, because certain people will feel that as life goes on and they get older, perhaps their sexual drive is not as it was when they were younger, and they consider that part of life. But that's not everybody. And so I know of people who are, on in age, mature, if I can put it like that, who this is really important to them, and they will absolutely seek help for it. So I think as healthcare providers, we always have to have a very open mind to be sure that we're looking after everybody's total health, and that includes their sexual health, as well as their general health, as well as their life living with diabetes. So it's brilliant. Frank, thank you so much. And also, as a world-renowned expert in prostate cancer in Black men, thank you so much for raising the issue of prostate cancer, because we'll put a link where people can do a risk assessment score to see. We've done this previously with diabetes, but we want to do this also with prostate cancer. So Professor Frank Chinagwendo, MBE, thank you so much.
Thank you very much, Joan. It's been a pleasure.